will you ask a question, or what is the plan? Are you Dr. Amin? Are you operating this machine?
Yeah, I think I was just waiting for it to go live. So
no,
so
we are all alive, but we are not hearing you. You are not saying anything.
Oh no, I was waiting for our meeting to go live on YouTube. It was still not active yet, but now we're live. So welcome to everyone who's watching, and welcome to the members who have participated in this meeting today. So this is our 9th intergenerational meeting, and today we'll be exploring the topic about approaching our patients. In particular, I think we'd like to explore approaching our psychiatric patients. So without any further delay, I think we can just jump into it. I'd like to begin by actually asking a very specific question that I actually had for some time, actually, ever since I had my exposure to my psychiatry rotation. Professor Sartorius, I actually want to ask, sometimes it gets a bit difficult when we want to empathize with our patients. Like, I know you're a very strong advocate for listening to our patients and taking the time to just not say anything for at least the first few minutes, for as however long as possible as we can, to try and empathize with the patient and just listen to what they want to share about their condition or what they're experiencing. But there's also the concern about like time constraints, and sometimes there's also the patients who come in with, what if they come in with complaints and then they go off on a tangent? How are we going to like bring them back if we are just listening sometimes? Or how about patients who tend to overshare certain things and they go off topic, or they have flight of ideas and they're jumping from one topic to another? So I've always wondered, how do we strike a balance between having empathy and, I won't say controlling the conversation, but maybe facilitating the conversation in such a way that can help us get information to help our patients?
Well, a good way to start is to take for example, a Zoom or a computer and sit for 5 minutes without speaking, just looking at it. Just sit there and wait for 5 minutes without doing anything. And that will give you a sense of time. It'll give you a sense what 5 minutes mean. When we normally get to talk to somebody, we are terribly worried and we start talking very quickly. But imagine because we don't have a clear idea of how much is a minute. And for example, now we have been, before you started talking, it was 17 seconds. And yet it looked very long. And I think that the discipline which you should learn is to be able to, in your mind, to measure time. Now, you know that you will have, when you sit with a patient, maybe 10 minutes or 15 minutes of time, but that is not clear in one's mind. And so one rushes through things and very often gets into irrelevant things because you are concerned that you will not get everything done in time. So first one is learning how time flows. It's a very difficult. And for example, in some of the religions, this is a discipline in which you learn how to measure time in your mind, that you know what is 5 minutes, what is 4 minutes, what is 7 minutes, etc. Once you have that as a first task of learning this, you may then wish to, when you see your next patient, put the clock down and say, how are things? And not speak for a minute. Just wait for the patient. Sooner or later, maybe you can say one word of encouragement, but try to discipline yourself to have a minute or maybe 2 minutes, leaving the patients in peace, because people are afraid of you. They think that you are a great doctor. They don't want to disturb you. They want to be polite, and they don't say anything. So give them a minute, but you can only give them a minute if you shut up and if you do not speak. And if in fact you sit there friendly, listening, but waiting. And I think you will discover that you are getting into what is called the registers. Now, a register in a conversation is a style that you are using for different groups of people. You're using a different style of conversation with a beggar, with a professor, with a patient, and with your wife. There are different registers. And in that register, there is a series of words which are used and other words which you do not use. And so you have to recognize that it's very helpful for a patient to have an opportunity to speak in two registers, the register of patient and the register of human being. They are very different, completely different. In fact, as a human being, he may be quite angry with himself for having these symptoms. But as a patient, he's terribly concerned with the symptom and wants to tell you about it. So you have to make sure that your short conversation with the patient is composed of at least two registers. The register of the patient as a human being, register of the patient as a patient. You may, as time goes by, add other registers. For example, if the patient is a great expert in cooking, you may wish to have 30 minutes, 30 seconds in which he can tell you about the most recent dish that he has produced. Or if he's a great expert in gardening, you may find out what he does in order that his roses are blooming and yours are not. But that's a different register. People speak in registers, and once they are entered into a register, they cannot get out. So you must break that register and move to a different one. You will discover that suddenly your time with the patient, which is short, is extended. And the patient will feel the same. You have, in fact, spoken to the patient as a human being, as a friend whom you met. You spoke to the patient as a patient, and maybe you've given him a chance to tell you something which is very clever, or maybe yourself have given your chance to yourself to say about something that you know that is unusual and that the patient might wish to know. So keep that in mind, and above all, try to discipline yourself to learn how to measure time without a clock. Very difficult, but it can be learned. Because you cannot watch at the clock and say, wait a minute now, I will now be silent for a minute. No, no, no. You must learn how to be at ease without speaking, being ready to listen and indicate by your body position and by your face and that you're now ready to speak. You're now ready to listen. But that's what I would suggest you do.
Yeah, I think that's a very interesting perspective that I never really thought of before. Like looking at it from not only a temporal perspective, like with respect to like the time you spend just keeping silent, but also looking at making sure the patient has the ability to speak in those two registers. So like I'm just sort of curious, maybe this is going slightly off on a tangent. What are the registers for this type of meeting?
The second thing that goes with it is that you learn how to control your body language. If you are interested in listening to somebody, if you are surprised, maybe you will show a different face. If you're excited about something, what is going on? I mean, you change your body language, and you don't have to have a huge register, but maybe one in which you are forgiving and friendly and loving is a good register to use from time to time. But these are body language, and we are not aware of our body language. We are very often saying, don't speak with our body, and say, yes, please speak with our mouth. But we are sitting on the edge and saying, all right, now speak, please. But if you are in a hurry, the patient will feel that you are in a hurry. He will not speak to you, and he will just sit there, and time will go for nothing. So I think knowing yourself, your body language and your time perception, etc., will then make it possible to incorporate the conversation, even if you have a short time. When I was a young doctor, I was seeing between 20 and 30 patients an hour because we had very few psychiatrists. And in a way, it was meant that I have to do it quickly. But as time went by, I spoke to and learned from some of my senior colleagues. I think that I was quite helpful to the patients, although they had only a very brief time, because they have told me what to do with myself and what not to do with myself. And sometimes if you have a good friendship with the patient, you can really have an extremely short interview and yet be very helpful to the person who is before you. As you have with friends as well. Sometimes a simple hello with a smile is enough to convince them that you are still caring about them.
that just made me think about the other end of the spectrum as well, Prof. Like, what about patients who have poverty of speech, for example, those who don't really feel like speaking, or they are unable to speak for, like, those extended periods of time? How do we engage them in such a way, or encourage them to speak up and share their thoughts and experiences?
Paracelsus and Celsus, who was one of the doctors in old Rome about 2000 years ago, he had what is called a walking therapy. And the walking therapy was that he would take the patient and walk with him. And while they were walking, they were making comments about things, and then they walked for 10 minutes or half an hour. And that was, at the end of that, they parted. But the fact that they were together for a while was also very important. And I think that there are many things, and sometimes you find that patients are very reluctant to speak about their illness, or reluctant. But if you have an interest in this person who is your human being, you will have to explore what is it that he likes talking about. Maybe he hates talking about his illness, but he likes talking about bees because he's a great bee raiser and he knows how to make honey better than anybody else. Forget psychiatry, speak about bees. Because having spoken about bees, he will open his heart to you as well. So the silence is rarely complete. Sometimes yes, but very rarely it's complete everything. You will have to probe to discover which are the areas in which a person feels confident and willing to contribute something. And then we are also, of course, all of us are a little bit different. Some speak more, some speak less. So some patients will speak very little. Well, that's life.
What about you, Dr. Rodrigo? Do you have any experience or your own sharings, with regards to, approaching psychiatric patients, for example?
Well, I would just echo exactly what Professor Sartorius have talked about. I experienced a healthcare system where I was seeing, as Professor Sartorius mentioned, 20, 30 people in the morning, and then again 20, 30 people in the afternoon. And it was just a few minutes that you had with each individual. But I have also, not firsthand, but I have heard about a different system here in New Zealand where there is, for instance, a whole morning. If you're seeing someone for the first time, then you have a whole morning to connect with that person, or at least 4 hours as a minimum, if it is the first time that you're meeting with someone, which is at the other end of the spectrum. So that, in a way, I guess, determines what you're going to prioritize in the conversation. Out of these two potential approaches that you can have in your conversation, as Professor Sartorius was saying, you could either focus on if I'm not misremembering it, I guess you could classify it as idiographic and nosographic or something like that, if I'm not mistaken. But the uniqueness of the person that you're talking to, as an individual, this is a human being who is in front of you, who has had a life, likes and dislikes and things like that. And you want to know about that information because you want to know about the person as a whole. You want to know the person that is in front of you. But of course, it is a clinical conversation as well. So you also want to, within the details that are being shared with you, you want to collect those that would allow you to make a potential diagnosis, for instance, and then guide the therapeutic approach that you would take. And you want, ideally, if you have the time, to have those things, both things. You want to have this conversation that will allow you to formulate an hypothesis regarding diagnosis, but also you want a conversation that will allow you to know the uniqueness of the person that is in front of you, and challenges and resources and strengths and barriers and things like that. And I guess depending on how much time you have, you will potentially prioritize one over the other. The more time you have, the better chances you're going to have to get to know the person as a whole. The less time you have, I guess the more you're going to have to focus on the clinical side of things in that conversation. But regardless, I think that every time you meet a patient and you have a chance to have that conversation that allows you to know that person as a person, the next time you meet with that person, it is that uniqueness that brings the file to mind, so to speak. It is that, how's your kid doing? How's your partner doing? How are things at work? And it brings all the file into mind rather than a diagnosis. A diagnosis is less personal, but it is, and of course that helps with the connection that you want to have with them. So yeah, I fully agree with everything that Professor Sartorius was talking about. Yeah.
There is also one question which I forgot, and that is the art of asking a non-aggressive question. For example, if you were to say, you ask a patient, what do you think about the murder of Shinzo Abe? He was just shot. That's one way of asking that question. And it's one in which you will get a very poor answer, because he doesn't know what you think. He doesn't know whether you want him to be positive or negative, what register to use or whichever. So you would probably introduce such a question by saying, you know, I'm still perturbed by the killing of Shinzo, by the killing of the Japanese premier there. It really shook me to think that they could have shot him. What do you think about it? Where you have, in fact, opened the door to a discussion. Now he knows that you want to speak emotional aspects of that, not about the fact that Shinzo Abe wasn't looking after the Korean comfort women, but you want to know about, you were shocked by the fact that they should shoot such a man in front of the street, in the middle of the street. You have now opened a register of conversation. You've told him what kind of, and you do it very often by starting with yourself, or by starting, some people start usually with other people. Other people sometimes hear voices. Do you hear voices? That's not the best way to start about this, but it's a possible way, because it's a very sensitive matter to, some people have been hiding voices for a very long time because everybody runs away from them if they speak about it. So you have to really find a way to maybe by starting about unusual experiences that people sometimes have. And maybe you can report one of your own. I mean, for myself, you know, whenever there is a moon, full moon, I wake up and find myself talking nonsense. I mean, exaggerating, but you try to find a way in which you will indicate what is the type of conversation that you would like to have this. And you are also giving, in a way, permission to speak about unusual experiences. It's a permission. By giving an example of yourself, you open the door and say, this is the way in which you can speak to me, because he will then assume the same style of talking.
Yeah, I really like that that example that was given, like sharing your own experience to try and guide the patient into thinking, okay, into, you know, having an idea of what register they should, you know, answer the question in. I think that brings up another question in my mind, at least. I'm sure some of you might be thinking it as well. Is there a difference between our approach to psychiatric patients versus non-psychiatric patients? And if there is a difference, what exactly is that difference? So maybe Idil can share some thoughts. I think she's been deep in thought.
Just like to follow up on what Dr. Sartorius said. I think mentioning our own experiences in a way also destigmatizes, like it serves destigmatization within the conversation. So that's like very helpful for patients to open up, because there is this balance that we have to find, that we need to in some way normalize the experience that they're having, without reducing the value or the impact, the negative impact that it's having on them. So I think that was a really good point. I don't have much experience dealing with psychiatric patients, but I did work in a very busy ER for several months. Among the patient population, we did have psychiatric patients. And I think there are some very common principles that apply to all patient groups. However, when it comes to non-psychiatric patients, I think you are allowed a more rigid and algorithmic approach in acute settings, versus in psychiatric patients, you really have to be more flexible and more present in the conversation. And I think that's like a very important aspect of it. When it comes to listening to someone, you really have to be present there, and you have to understand that there isn't one sort of template that will fit all sorts of patients, or one fits all sort of solution. And when it comes to when you are going to change the focus of the conversation, when you're going to ask questions, it all boils down to the fact that you create that rapport with that patient. You see eye to them, and you understand, you try to figure out when to ask the right questions, when to interrupt or direct the patient towards one way within the course of that conversation. And you can only do that by being truly present in that conversation. And there are a lot of systematic structural things that we would have to address, whether our hospital systems or environments actually allow this sort of mindful approach towards patients, or whether we are like forced to rush towards diagnoses. And I think when it comes to communicating with psychiatric patients, the element of social support also creates has a bigger role compared to non-psychiatric patients. Like, what sort of social support that person needs? Do they have family support around them that can contribute to their story, their anamnesis, or their medical process? Do they have the means to take care of themselves? Like, what sort of means that you have in that hospital to address that sort of needs with this patient? I think that's very important. And this was something that I've often felt unprepared when I was in the emergency room. I wasn't particularly aware of what sort of things that we can offer to our patients when it comes to supporting them. And I think this is also something that varies a lot from like systems to systems. Right now, I'm preparing to do a residency in the US. Like, I'm preparing for the exams for that. And one question that keeps popping when I do practice questions is that how to approach a patient who is like antagonizing, who has antagonizing or violent behavior in the ER. And a very common practice here in my home country would be first trying to reason with the patient, but that's like done just for the sake of doing it. But right after that, opting for medication or restraints would be used in this like under-resourced, overcrowded emergency rooms. But in the questions that I come across while studying for USMLE, the first line treatment is taking a step back and offering the patient whether something to drink or to eat. So that sort of social assessment, that's sort of social first aid is the first line approach to creating that rapport with that patient. And it all boils down to the social means of that hospital or that healthcare system. If there's a unit that allows in that hospital that allows for you to provide something like that to the patient, to every patient that walks from the front door, but not just like one or two patients, then you can of course do that. But if you don't have that sort of like social services available in your hospital or that sort of means, then you wouldn't be able to do that. So I think it's very important for us to build our interpersonal communication skills, but also in order to truly be able to approach our patients and do right by them, it's also very important to address like what sort of structural changes are needed, and how we can actually establish that multidisciplinary team to address all the needs of our patients. So yeah, that's my 2 cents.
Well, one of the things that you should try is also to show that you are human.
Yeah.
Not humane, but human. You should also be humane, but I mean, you should be. I remember the change that happened to me. in my relation when I was a young psychiatrist. You know, I do not know, you probably have night duties as well, or full day when you stay for 24 hours. And the various people do various things. And one, I remember that I have at this time, on one occasion, I went down to the ward and I played chess with the patient. And it changed my entire relationship with all of the other patients. Because suddenly I was sitting there, instead of being in my room reading a stupid article of sorts, or or sleeping, I was sitting there and I was playing and I lost the game and it was wonderful. Everybody was reporting. Suddenly I became somebody to whom you can speak, who is not a mystery. Now, there are many things that you can do to show that you are human. You can, for example, come to the patient's bed and you can when he sits there or something, you can help him to put the cushion in the right place because the cushion is in the wrong place. So maybe bring the water closer. But somehow you have to learn how to exit from the role of a doctor into the role of a friend, and then come back into the role of the doctor when you have to give advice, etc. But moments when you can show that you are quite happy to play chess or to do other things with patients, or maybe walk with them or whichever, is very important for your image, because patients talk to one another and they say who is a good doctor. And the good doctor gets all the information and very quickly. The bad doctor doesn't. And they know more about you than you will ever think they do, because you are the door to the world for them. And the other thing which I think is important, you were asking whether it's the same for physical patients and mental patients. Most of the physical illnesses are related and located in a particular place. Like if you have a painful leg, it's the leg which is ill. And you as a human being speak about the leg as a subject that is outside of everything. It's the leg which we are discussing. But in psychiatry, it's not like that. It is never only a part that is involved. It is always the whole person who is anxious, or who is angry, or who is afraid, or who hears voices. It's never, you cannot isolate psychiatric symptoms and say, well, my left leg is painful, doctor. And then we both, the doctor and the patient, look at the leg. In a way, the patient is your friend in looking at this leg. It's not that he is the leg. He is not completely ill. He just has a little piece of his body which is ill. While in psychiatry, you approach the patient who his entire self is involved in this particular experience which he has during his illness. That's another thing to remember. I will have to leave you very soon because I have to go, as I said. I hope that you can continue a little while, and I hope to be able to see you on some other occasion in Bulens Choshkun's. But you should try not to do it on Sundays. Many people will be finding it a bit difficult, although there are some masochists which like to work on Sundays as well. Most of us are not ready to sacrifice all days, but it's a rule of every 10th of the month. The 10 meaning, yeah, I think that Professor Choshkun has selected the number 10 in the months because the number 10 in China is the sign which you have for the number 10 is the sign for life. So that in fact, it's meetings about life. And that is something that is very nice symbolically. All right.
May I say a few words? Well, the reason for choosing 10 was due to 10th of October, which we try to put it in our minds. You're right. I know you. It's Sunday is much important for you due to the family. But before having you go, can I ask you something? What should be the balance between talking about oneself and not talking about oneself? I mean, in our traditional training, as it says, in my home country, we were used to hearing that we should not talk about too much ourselves because the person in front of us would be challenged with the types, the way we have handled our problems, and he or she may be challenged if we are giving examples from ourselves. But as time passed by, yeah, all right, please, go ahead.
I think that you should use the example of yourself or personal as a key to a conversation which will be about illness and about other things. So excessive and telling a patient everything about yourself would be foolish. But using an example or a particular small detail to show that you are willing to listen, you are in fact indicating, you're giving the patient indications of how you would like to have this conversation, that you would like the conversation to be open and that it's all right to express his feelings, etc. And you indicate this by these brief introductions that you have and by carefully listening and so forth. Of course, you will not tell the patient everything about your life, because then the roles are inverted and he will tell you, all right, doctor, take some tranquilizers and come back in a few weeks. But he will, a little sign of indication that you are happy and interested in listening both to the disease part and also that you are respecting him or her as being a person whom you've just met and whom you want to help because he is a human being. You have to indicate that to people, and you will be surprised to see that sometimes they at least in part improve to please you. I mean, they feel that they are giving you a gift when they are better. And that's quite nice to know as well, that you have used the, so to say, respect in order to get them to work a little bit more on themselves and to be. So I would say, no, you don't disclose yourself completely, but you use, occasionally you use indications of your own problem because that will allow the patient to speak about, because patients, for many of the things, they think they are either banal or you cannot speak about it. I mean, one good example of that is an area that is so difficult to many young doctors to enter into the questions of details of sexual life. Now, in many countries, this is a very difficult proposition because people don't normally speak, particularly if it's a male speaking with a female and vice versa. So to learn how to open that topic, being respectful, but at the same time having to find out, because that's what life is, no? I mean, you want to know about that one as well, requires a great amount of care and respect. And I think that the word respect for the patient is a very important one. You have to think about the patient, not only about as being a person who wants your help, but also being somebody who is equal to you or better than you in general life. That will make the atmosphere, I think, right. And it will come to you normal. You will suddenly discover that there's no problem, I mean, that you normally approach, but in the beginning, it's sometimes a bit difficult. When you go to America, Dr. Is it Kina? Yeah. You might wish to read two books. One is called The House of God, which is a description of American hospitals, which you will perhaps find a little bit unusual. It's quite a bad book, but I mean, it's worth glancing through it. And the other one is called In Two Minds, which is written by a young psychiatrist who is a daughter of a much older psychiatrist and much more well-known psychiatrist. In Two Minds is a description of her experience. She became later an anthropologist, description of her experience in training in the United States for becoming a psychiatrist. So you might find those two books of interest. And since the likelihood that you will wait on the airport for a long time is very high, you might wish to read this while you're waiting.
Thank you.
All right. All the best, and thank you very much for listening. And thank you, Bülent, for inviting me. Thank you very much.
We thank you a lot. Your contributions have been invaluable indeed. Thank you.
Thank you very much.
Yes, Ramin, thank you also for carrying out with very important questions.
Yeah, I think, well, since there's still, I mean, four of us are still around, I'm just wondering, are there any other thoughts we would want to, throw around to have a quick discussion before we decide to close the meeting?
I would like to add the concept of suicide, similar to sex-related issues. It's also a very hard question or a hard issue to talk about, especially during the beginning of the adventure of psychiatry, or any kind of physical, for the physician, it's a hard issue. There may be some critical questions when we do not want to mention the word suicide. For me, it was useful to talk about how you feel about life in general. Then the patient may start, oh, doctor, you are talking about life. I'm thinking about leaving this world. That would immediately bring him or her to the topic. And there may be another step later. Well, fine, he may or she may say, what do you think about life in general? And what do you think about 10 years ahead? What is your thoughts about the future? Might also be useful to talk about the willingness of the patient to continue his life or to bring it to an end. That's also an important part I wanted to underline.
Yeah, I do agree. I think
and even after spending 40 years in psychiatry, as you see, there is always things to learn to bring you up. I used to think about this as the content or of the human being of that person. We should first get some information about how he or she lives in the usual way of presenting cases. Our residents want to talk about the symptoms and the history of the problems, but I always try to insist that first, let's know where this person is from, what kind of a family he is from, what does he like or he doesn't like. I fully agree with what Dr. Sartorius says. The person may not want to talk about some issues. We used to work with adolescents, and my residents would come and say, he or she doesn't speak. Well, let's ask what he likes. He said, talking about bees. I was very interested to hear the stories of cats and dogs. That really opens up the way for human relations. These were the small points I would like to add.
Dr. Joshkun, I think especially like the last point you underlined, it just shows how much psychiatric conditions involve a human, like a person's full personhood, rather than like just an organ or just a part of their body, as Dr. Sartorius also mentioned. It really does take to, like in every discipline of medicine, they say you should always treat the patient as a whole, but when it comes to psychiatry, it really does take knowing the whole person in order to understand what they're truly going through and in order to help them. So I think that's a very important concept for us to internalize so that we can approach our patients in the right way. So yeah.
Ramin, you kept asking questions and moderating. What about your experiences?
I actually do have one interesting experience, which is in line with, I mean, it's sort of, you know, I could relate to what Professor Sartorius mentioned when he talked about, you know, playing chess with a patient. There was this one patient who came in, she was admitted into the ward, and, you know, the doctors were actually having a hard time, you know, getting, you know, some, the information out of her. So, a few of my friends, you know, we went there and we were trying to, you know, speak to the patient and get some idea, but she was not too forthcoming at the time. So I happened to get out from her that she actually likes to play ping pong, and at our hospital facility, we actually have a ping pong table and a setup and all that. So I just invited her, come, let's just play ping pong for a while. You know, maybe it can, you know, at least it can make you feel better in some way. So, and that's what I was thinking at the moment. So we ended up playing, and she just blurted out that I haven't had this much, I haven't seen the light in life in so long until now. So we got into a conversation, and we actually managed to get, you know, some of the details from her, and it helped us understand what she was going through, and yeah, we tried to relate to the you know, her treating physicians and so on. So yeah, I think that was a very eye-opening experience for me. So yeah, I could definitely relate to that. Sometimes we have to put you know, bring ourselves down into like the human level, and then, you know, back up to the physicians or the doctor's level for our patients.
I would just compliment. Yeah. I would just compliment that, Ramin, with like when we're doing a physical exam, and we need to fill a report afterwards. We often are taught to follow this structure, and we start at the top of the head, so to speak, and we end with the fingernails at the toes at the end, and we go through the whole body, because we need to write, or we need to report, like in emergency departments, someone comes in and you need to report in like 5 minutes before the next round. You have pupils, I don't know, and you go through the whole formula. I would say that for psychiatric assessments, you also, with repetition, end up developing that sort of formula. You know the kind of things that you need to report in terms of a clinical assessment, consciousness, alertness, orientation in time and place, thought, content, and structure, speech, mood, affect, and you develop by repetition this sort of formula. And once it's ingrained in your mind, because you have done it so many times, it becomes almost instinctive when you're having a conversation with someone. The boxes are being checked in your mind. You're just having a conversation with someone, but through that conversation, you are collecting information about alertness, orientation in time and place, thought, content, and structure, and speech, and mood, and effect. And you instinctively recognize if there is a missing area on your clinical assessment, so that when it comes close to the end or at some point in the conversation, you can, I might need to ask you some direct questions now. How about this? How about that? And you end checking the boxes of your clinical assessment. And then the thing that having this structure in mind, it helps with, is that you can allow the conversation to flow in whichever direction it is going, because you are mindful of what has been assessed. and what hasn't been assessed yet. So you can share control of the conversation with the person in front of you, and ask for it again when you need to ask for certain things, and give it back again, and let the conversation flow in whichever direction it needs to go. So I would say, yes, it's important to have a structure in mind. Let share control of the conversation, and of course, something I wouldn't recommend, but I used to do, it was, I would offer a cigarette but I wouldn't recommend you do that. But the first thing we would do, and because he was kind of rebellious, we would go close to the window at the hospital and, do you want a cigarette? And we would go next to the window. And it was the first thing I did, like, and hi, how are you? Please come in. I'm going to have a cigarette. Do you want to, without even like, what brings you here or how can I help you? Because it was kind of like to ease the person's mind. They are very afraid of what your first question is going to be. Imagine the first question is, would you like a cup of tea? Would you like to start a session with a prayer? I don't know, whatever is necessary. Talking again about the humanity of it all. And this is going to be my last contribution, but things can be a bit different when it comes to addictions. Something to keep in mind, but because when it comes to addictions, I think an important aspect to keep in mind is that you might be able very quickly to assess or not the presence of a substance use disorder. Has there been loss of control, attempts to quit unsuccessful, etc., and your 11 criteria. So very quickly you might reach the point of having checked all the boxes and you have a diagnosis in mind. But then the issue turns upside down, because the expert of what the situation is and the only driving force towards change outside of that situation is going to be the person in front of you. There is very little you can do in terms of being the driver of change. So here is where this whole idea of motivational interviewing style comes into play, where you are trying to elicit change talk and to recognize it and elicit that internal motivation to change the current situation. And once you have your diagnosis, here it becomes essential to have this idea of what the situation is around the addiction, so to speak, because you want to know what the person is doing on a regular basis, and where are the challenges, and where are the resources and strengths, what can they draw from, and what they might need to avoid, and what relationships might need to change, and a new identity might need to be formed, and that means loss, and that means grief. So there is potentially with addictions a whole different style needed of conversation that the one you would have with someone, let's say, for instance, with depression or anxiety disorder or psychosis, etc. But yeah, sorry, those were my 2 cents.
Thank you. Those were very important contributions, of course. I have 2 points to make. We used to have our meetings for about 90 minutes. I understand we do not have to. We could very well do with an hour or even less, which would be easier, which would make it easier to follow, to watch. And the second point, today we have talked about mainly with the patients, relationships with the patients. Of course, it has many other groups to talk, but maybe we could spend another 10th of any month about relatives. The patients are brought in sometimes by their relatives, or they may not be relatives, but someone who takes care of the person. So that could be another topic to work on. If you would all agree, I would suggest to turn around with the last words and bring to an end for today. Any additional words you would like to say?
just to say thank you, Ramin, you for taking the lead in the moderation and on the spot and doing an excellent job as you have done it as always. Yeah, just that. Yeah.
No, I think other people should be given an opportunity as well. I think it's a very interesting and a little bit scary, but it's a very interesting and valuable experience, I would say. I just wish more of our members could experience it as well in the future. Yeah, thank you all for sharing your thoughts as well.
Thank you. Idil, nothing to say?
Just thank you all. It was a really fun meeting as always. It's a blast to have these discussions with you guys. And I'm